Nice to have you with us once again. The relentless rise in the cost of healthcare means that medical aid is not just an option, it's become a must-have. Healthcare costs as well have been rising, and that's what we're looking at in the show this time around. Joining me in the studio, Heidi Kruger, who is spokesperson for BHF, and Nondumiso Khumalo, who is a senior health economist at the Council for Medical Schemes. Ladies, it's very nice to have females, to be surrounded by females for a change. Let's just go through what you do and what your organizations do. Heidi, let's start with you.
I'm Head of Corporate Communications for the Board of Healthcare Funders, which is the representative body for medical schemes, administrators and managed care organisations throughout Southern Africa. Okay, so all of Southern Africa's medical aid schemes and administrators are members, or most of them are members of the right. Nondumiso?
Nondumiso Khumalo. I am a senior health economist at the Council for Medical Schemes. Within the department that I work for, we do a lot of research, macroeconomic analysis, including microeconomic analysis of the conditions or the market conditions within the medical schemes environment to be able to advise the council on the best regulatory approach to take so as to address whatever condition that we might have observed.
How did you get into that job? Because that is a very specific position.
It is, but I mean, it's health economics. Even though there is a shortage of supply of health economists within South Africa, but you find a lot of those people in the industry as well as in the academic sector who are doing a lot of work doing micro-analysis of public health interventions as well as cost-effective analysis, economic evaluation of a variety of programs. So I started working at the University of Witwatersrand in the Center for Health Economist as a junior health economist, and from there I've grown, really.
It's just such a targeted career to go into. It fascinates me.
Except that we mediate a lot of money. I mean, the private healthcare system in South Africa is worth something like 110 billion rand a year, 8.5% of GDP. The health takes up that amount of GDP.
8.5% of GDP.
Yeah, that's the public and the private combined. But in the private sector, it's 110 billion rand a year industry. So it's huge.
Okay,
it is huge.
It's huge, but it's also very, very expensive. Where are all of these costs coming in?
Well, I think it's very important to start with the fact that a medical scheme is not allowed to make profit. It's a collective. So the medical scheme collects money from all its members, and depending on the needs of those members, that's how much money it's got to pay out. And so if the needs of the members or the regulatory requirements or the environment changes or gets more expensive, they have to collect more in contributions.
So every cent paid into a medical scheme is being paid out?
Yes, except for 25%, which is a solvency ratio and required by regulation.
Okay. So this may sound like a really stupid question, but how do medical aids make money?
They're not allowed to make money. They're trusts.
They're just supposed to collect contributions from members and collect them into central big fund, and they're supposed to maintain it because those are mutual funds.
That's right.
There's not supposed to be any profit making within those entities, and they're supposed to ensure that each and every claim, of course, they have to review the claims that they receive to detect whether is it, to look at things such as fraud and corruption, moral hazard by members, whereby they will just be overutilizing healthcare services with no healthcare need, and to detect those sort of things to ensure that they pay for the right claims, and that is cost-effective management of the actual fund, and that is the members' money.
I mean, universally, healthcare costs are above general inflation. Universally, that's true.
But why are ours so high?
But they're contributing factors in South Africa which don't occur in other places in the world.
Like
I mean, universally, you'll find, for instance, an aging membership. For instance, new technology, which is expensive. In South Africa, we have additional things. We have a whole lot of regulatory requirements which push up the costs, and one of those is, for instance, the prescribed minimum benefits, which is a basket of conditions that every medical scheme must cover in full for every one of its members on every one of its benefit options. But on the other side, and they're mostly high cost conditions like hospitalization and specialist-based conditions, but on the other side, there's no tariff in the environment at the moment. There used to be a kind of guideline tariff, but that's been scrapped by the High Court for some procedural reason. And at the moment, there's no tariff. So in actual fact...
Wait, hang on, talk English to me now.
Yes.
Because I'm not understanding your medical speak. When you say there's no tariff...
A list of charges.
So there was a list of charges saying if you're going to a specialist, we will pay X amount.
Yeah.
Yes.
Has that tariff been thrown out the window?
Yeah, those were like guidelines.
It was a reference price list, but everybody adhered to that. And then, in fact, the funders and the providers used to come together to negotiate those fees.
Okay.
So the medical aides used to sit around the table with the hospitals and the specialists and various disciplines, and the medical aides used to say, well, for a tonsillectomy, we can afford to pay this. For a night in hospital, we can afford to pay this. And they used to agree on a tariff. And then when the kind of newly established competition commissioner came in
2004.
They accused the industry of collusion. They said that even though the medical schemes were pushing the cost down for the purchaser, i.e. the consumer, it was collusionary what we were doing. And so we had to stop doing that. And since then, we've just seen costs skyrocket.
But Nondumiso, correct me here if I'm sounding like a moron. But surely if the medical schemes were pushing the prices down to the benefit of the consumer, where does the collusion side come into it? Because you have to collude, you have to agree.
Yeah.
It's like me saying, come and work for me as a health economist, this is what I'm prepared to pay you.
Exactly.
If you don't like it, you walk away.
Yeah.
Exactly.
If you do... So this is not making a huge amount of sense to me, but that's not the reason we're here. But I just want to put that on the table.
Yeah.
I also want to place on record that it's actually lovely having, I've said it's lovely having two ladies here, but I don't have to do any work because these two just talk amongst each other. And they go, yes, and I agree. And you know, I don't know why they do that either. I know, and it's actually wonderful. So I'm just going to sit back here and let them carry on.
I just want to shed some light,
yes,
if you would allow, the issue of PMB. You know that they're there to the prescribed minimum benefits, what Heidi was talking about just now. They're there to protect members against high catastrophic costs that are associated with those conditions that have been identified within that basket of PMB conditions. And I mean, there is a social good for having such protection for members.
Absolutely.
But there are other factors that contribute to the escalation of costs beyond the PMB requirement. You have issues such as the private hospital market that is highly concentrated. It is a natural monopoly. They enjoy massive advantage. And within that sector, you have like barriers of entry for new hospitals. We know where if they could be able to enter that market, there would be some form of competition that we would start to see. I'm talking, for example, about the private hospital licensing process, which is actually under the mandate or oversight of the National Department of Health. And if you can just provide more capacity in those departments and ensure that you start to sort of allow registration for corporatized hospitals, maybe not-for-profit entities per se, like almost like in the NHS, that are run along the lines of the private healthcare market, but that are not there to generate profits. You know, as long as they are providing good quality healthcare services, then they would compete with the big hospital groups that are highly concentrated in the market. So that is one of the big problems that we experience, and schemes end up being
absolutely,
and schemes
the shortage of specialists is another thing. You know, there's a huge shortage of specialists in the country, and
why?
And as a result of the no tariff, pretty much people can charge whatever they like, and that puts the cost up.
Why is there such a shortage? Are we not generating as many specialists?
We're not generating as many as we need.
And migration is a problem as well.
Migration is a big problem. So they're just
we live in a global village at this stage.
Exactly, and those are scarce skills in the world.
Okay, from what I'm understanding, you've got your private healthcare providers sitting there. You've got government services sitting here, which the minister is intent on including or pulling these two together to bring out this thing called national health.
Yes.
Before I get to what my proposal would be as a layman, I just want, we've got a few minutes before we have to go to the break.
Okay.
I just want your individual opinions on national health.
The concept of universal coverage is absolutely sound. Our health system at the moment, with this two-tier system, with most of the providers sitting in the private sector, the problems we have in the private sector, which we've only just got to the tip of the iceberg, and the problems in the public sector, like lack of human resources, like a huge burden of disease. It's a no-brainer to me to try and make one cohesive health system, incorporating them both, which is what the proposal essentially is.
Would you agree with that?
No, as CMS, we actually support NHI as it is proposed by the National Department of Health. And pretty much because as much as people often say that private health care is efficient, as there is good quality health care, we don't see that. Our experience is quite different. And when we try to engage with the private providers to give us access to their data so that we can assess these clinical health outcomes that they often speak about, we don't get access to their data. So we believe that actually the Minister has a bigger role to ensure that each and everybody in South Africa has equitable access to healthcare services. And NHI is one way of achieving such an objective. So CMS does support, and in fact, we have provided various input to the Ministerial Advisory Committee, as and when requested by the Minister. And we do think that equity is an important thing, even within the medical schemes environment. Even if you're just looking at that sector alone, equity, affordability and sustainability of it is very important.
We can expand coverage.
But
certainly, I mean, I think that there's expertise in the private sector that needs to be utilized within the NHI. But for us, it's just a no-brainer. You need a proper healthcare system that's universal coverage for everybody.
You've put your cards right on the table.
Yeah.
I'd like to we're going to a break right now, but I'd like to come back and propose another model which we can thrash out and have a look at, and I'm sure you've got a whole lot of issues that you want to bring up as well. More with Heidi and Nondumiso after this quick break. Stay tuned. Talking about healthcare and the price involved in healthcare, which I'm sure is hitting a lot of people's pockets. I know it is hitting mine. We're chatting to Heidi Kruger, who's a spokesperson for BHF, and Nondumiso Khumalo, who's a senior health economist at the Council for Medical Schemes. Now, let's get back to my scheme. Yes. Okay, the Mansfield scheme. If you've got the private healthcare clinics over there and you've got the government healthcare providers over here, surely there is a gap in the market between the two. Instead of pulling them together, which there seems to be a bit of edginess about, more from the private sector than from...
We haven't seen the details of the proposed national health. It's too early.
But surely there is a gap here for a semi-private government fund, a sort of half and half, for want of a better word,
we have
provision.
We have a government employers medical scheme, which is called GEMS, which is, I think, sort of what you're talking about. I mean, it's for civil servants. It's a restricted scheme, so only those civil servants can join.
But I'm talking about the population as general.
Yeah.
Is it working for the civil servants?
They come under the same sort of threats and difficulties as every other medical scheme does, i.e. the costs go up. I mean, they are subsidized to some degree, but there's something called the Medical Schemes Act, which every medical scheme has to adhere to and by. And if you're going to bring in a medical scheme, even if it's something sitting in the middle there, it's going to be subject to the same sort of vagaries as...
So it's not going to work?
Yeah. I can't see it.
Damn.
I
thought I was going to go out there and
solve the problem.
Yeah, solve South Africa's healthcare problems in one show.
And I think if you can look at the PPPs, the public-private partnerships that have been started by various actors in the market, whether by the private hospital groups, in partnership with the Department of Health. You would see some of those have been successful in trying to bridge the gap. But those PPPs, it takes very long for the government to realize the actual benefit and value of such. I'm not sure whether you've heard about Inkosi Albert Lutuli in eThekwini, which is one of the big tertiary hospital which was built as a PPP. Yeah. So theoretically, it seeks to address that gap that you're talking about, whereby the private sector comes closer to the public sector and they say, let's work together and see if we can assist in creating a world-class hospital that is almost of similar nature to a private hospital, but that is functioning within the public space. But for government to actually realize the actual benefit of such PPP programs, you have to wait. It takes time, close to 30 years, between 15 to 30 years.
And in fact, we've seen the Minister of Health putting a lot of resources into the public sector hospitals just of late.
Yeah.
The tax
revitalization program,
the tax allocation to public sector facilities has been increased. And one of the things that will provide once those infrastructures are upgraded and the human resources issue is taken care of, is that those hospitals become a viable competitor to our private sector facilities,
which is good. Yes.
And it'll contain the costs or push the prices down.
Just before we get on to both of your la-la lands in medicine, where you would like to see all the little fairies jumping around and life's wonderful for everybody. There is a threat, it's been in existence for quite a while now, but there is a threat that our highly qualified medical staff, from nurses all the way up to specialists, are being ripped away from our shores by higher paying jobs and better conditions. I can't see that stopping in any way.
No, I don't think it's going to stop, but the Department of Health commissioned a study into human resources and what they need to do and all the rest. It's a very, very thick tome of a document, actually. And I mean, the upshot is that if you're losing people, you just have to train more.
Yeah.
And the government have the intention and probably proposals at this stage to train more people. Because that's what you need to do.
Are we training enough people?
I know they've certainly increased the
number of people they're training, and they also, at some point, there was a talk about mid-level workers, which would be people that you sort of lock in your country. Maybe like a mid-level worker between a GP and a professional nurse would be something in between, but it would be a human resource that could only be recognized in South Africa to provide a defined scope of practice, and that is just that was one of the ways that the Department of Health was thinking of addressing the human resource problem.
And I think that's a really good idea. And one of the things under the NHI proposal, the Green Paper, is that you'll have to access a primary care provider before you get referred upwards to an expensive specialist. Yeah. Just like what happens under the NHS in the UK. Yes. You're not allowed to go straight to a specialist.
No, you've got to have a letter recommendation from a GP.
However, on our private sector, I mean, I don't know anybody that goes to the GP, especially if their child has got a cold or something, you'll go straight to the paediatrician. And that's really expensive stuff. It's taking the time away from the paediatrician of stuff that they specialised in, making them do primary care work.
I only asked that question from the bottom up because I was recently in Penang in Malaysia, and a friend of my brother-in-law's is an ex-South African specialist who's working in Penang now, and he showed me around the government hospital he works in, and there is a nurses' college attached to the hospital where they have 800 nurses who are in training. They're given board, lodging, food, uniforms, all the rest of it. At the end of their training, they have to work for the government for 3 years. And it's their community service.
It's a very sound principle.
It's something that we should maybe... Right, let's go to La La Land.
Okay.
In Heidi's La La Land, what would be happening? And I'm going to give you, Nondumiso, I'm going to give you a bit more time to think about this one. What would you have happening in this medical world? And I'm talking all nice and softly now because we're talking La La Land.
Of course. And in my world, everybody in South Africa would have equal access to good quality medicine whether you access a midwife or a nurse first and then a GP and then a specialist, however we did it, but that there was enough preventative and private and primary health care thrown into the mix so that you save the costs on your high cost intervention, so that you have more money for more stuff. Because remember, a health system is who are we going to cover, how are we going to raise the money to cover it, and what basket of benefits are we going to cover.
So you're saying you've got to go from this bottom-up approach where you're feeding people into...
Have to. The other thing you have to ensure in any health system is that the healthy people cross-subsidize the ill. So in any pool of people covered under a health system, you need lots of healthy people and young people, and you need, so that they will cross-subsidize your elderly and sick.
Well, that's part of the problem, isn't it? And it's not only in South Africa, it's a worldwide problem. I mean,
it's a worldwide problem, but that also...
The aging.
Yes, of course. But that also means that everybody has to contribute equally. And when I say equally, I don't say that has to be the same amount of money from me and from you. The more you earn, the more you should pay.
But
it's a progressive system.
So for want of a better system, we say 1% of your net salary will go into medical, whether that means you're earning 160 Rand a day or 160 million Rand a year.
Exactly.
1% goes into medical.
Exactly.
Come on, The Economist. If we did something like that, you would be able to get to a percentage.
Yes.
Would that solve a lot of the problems in this country if everyone was paying their way?
Of course, because then you would have a bigger pool of people participating in this big fund, and there would be sufficient cross-subsidization, as Heidi mentioned. But I think the other important thing, other than just looking at the supply side factors, member behavior is also very important. I've observed in the media, they often look at the private providers, especially, of course they are culprits, but also member activism is very important. Part of the cost escalation that you're seeing there, which would be captured either in terms of increased in utilization, could be due to member behavior. Specifically here, I'm talking about overutilization of healthcare services by members if there is no clinical need to do so. Just because you have a medical aid cover doesn't mean that you have to ensure that by the end of the financial year, you must have used all your benefits, because the scheme will then capture that as actual utilization. It's claims, and then when they project for their contribution increase, they're going to look at their past claims experience to project forward in order to increase your premiums. So I would say that members need to understand the impact of their behavior. The problem that is linked to anti-selection, when members decide that because they are young and healthy, they're not going to join the medical schemes at the moment. They're going to wait until they are old, and the probability of them requiring extensive, costly health care is high, then they start joining. Then the medical schemes are going to, you're limiting the extent of cross-subsidization. And the schemes, the Medical Schemes Act allows the schemes to then charge like a late joiner penalty. You can avoid that penalty if you join early, especially if you have means to join the medical schemes environment early. And out-of-pocket payments, for example, you hear various estimates that have been thrown out between 10 to 15% of the household budget being out-of-pocket payment for healthcare. And actually that's quite high, but if members would take time to understand the benefit options that they've purchased, their scheme rules, how to avoid having to pay core payments, how to avoid a balance billing. If you've purchased a network option, understand that it's a network option, and you must know that who are the designated service provider for you for that catchment area where you are, because once you go outside a network, whilst you've purchased a network option, you're going to have to pay either full amount out of pocket or there will be some core payment, and that also goes back to the system, and we see it as expenditure in the private.
But isn't part of this problem, and we are running out of time, so I'm going to ask for a brief answer here, Heidi, if you can give me one. Isn't part of this problem that 90%, I'm throwing that out as a pure number, 90% of the people in this country who have medical aid don't actually understand what their medical aid is all about?
No, you're absolutely right. It's a complex environment, but if I can give one bit of advice is read the rules of your scheme, know what you're covered for, know what the scheme is going to pay out, and know who you can go and visit, you know, if you need a doctor, if you've got a network as an option, as Nondumiso says. But the other thing, just following on from Nondumiso, I think that it's, you know, the responsibility lies with the consumer, because you know, as much as there's consumer behavior, we're also responsible for our own lifestyle. And so, you know, two of the big cost drivers are obesity and diabetes, and those are lifestyle diseases.
Well, you see, once again, as we say, as we've said so often on this show, it actually does come down to the individual. It comes back to us. And we can't just say, oh, well, I've paid my medical aid, so I can go and do whatever I want to.
Not.
It does come back to us, and we need to take responsibility
for that. It's your money in that trust fund.
Yeah.
And you have to take responsibility.
That's actually the best way of looking at it. If you next time you look at your medical aid, it's your money in that trust fund, and it's up to you to make sure the trust works properly, not only for you, but for all the other people in that trust. Ladies, thank you very much. I'm sorry we're out of time. I could have carried on for another 5 hours with you, because I could have walked out, had a cup of coffee, come back, and nobody would have even known that I wasn't here, because they would have carried on. Thank you very much for your time.